what you can do to improve access to optimal screening. I may cover some of the slides quickly, but as you just heard, they will be posted online so you can read them tomorrow and later at your own pace. So let's review. What is breast cancer? It's a disease where a group of cells loses their normal control and they grow, usually into a lump, and they can invade and damage the adjacent normal tissue. They can also spread to other parts of the body, like nearby or distant lymph nodes, and other organs like lung, bone, brain, and etc. But we know that many cancers can be found before this happens, when they can be treated more easily. You've heard that 1 in 8 statistic, but that's not across all ages. Breast cancer is very uncommon, but it still occurs in the 20s and 30s. The incidence jumps dramatically in the 40s to about 1 in 69, so we're still not at 1 in 8, and it keeps rising and it never drops. Women sometimes tell me that they don't need a mammogram now that they're 60 or 70, but unless a woman dies of another disease, her risk of breast cancer keeps climbing. Many of you may live in provinces where screening mammography isn't offered to women aged 40 to 49, and some of you may have been diagnosed with breast cancer in more advanced stages as a result. Here are some important statistics showing why it's important to start screening with mammography at age 40. 1 in 6 breast cancers is diagnosed in women in their 40s, and 41% of the years of life lost to breast cancer are in women diagnosed in their 40s. There's a website called End the Confusion that has references and lots more information that you can share, and you can see the reference there. There are factors that increase a woman's risk of getting breast cancer, many of which are beyond our control, and those are listed on the left. The list on the right is a list of factors you can control to reduce your risk of getting breast cancer or getting a recurrence. For example, minimal or no estrogen therapy after menopause. Minimal or no alcohol. Nobody likes hearing that. There's a linear relationship between the alcohol intake and breast cancer risk. A low-fat diet, moderate exercise, not smoking, and attaining and maintaining a healthy body weight. But please remember, we are all at risk. The biggest risk to get breast cancer is being female, and the second biggest risk is getting older. I have women sometimes say to me, I don't need a mammogram because no one in my family has had breast cancer. But the fact is, 75% of breast cancers occur in women with no family history. We screen with mammography and other tests to find cancers early to save lives. But also, in addition to saving lives, we want to find cancers early so they can be treated with less aggressive therapy. When cancer is found early, a woman may be a candidate to not have a mastectomy, but have a lumpectomy. If it's found early, she can avoid having the big armpit surgery called an axillary dissection, which has a complication of lymphedema, and she can have a less invasive test called a sentinel node biopsy, which has a lower risk of lymphedema. And now, when cancer is diagnosed early, many women can safely avoid chemotherapy. So that's why we screen to find cancers early. Now, different tests can be used, and today I'm going to focus on mammography and ultrasound, but I will talk about some of the other tests at the end. MRI is reserved for women at high and very high risk, like women who have the breast cancer gene. But I want to stress that thermography has been thoroughly discredited. It can find big cancers close to the skin, but those aren't a problem for us. It misses smaller cancers deeper in the breast, and it has loads of false positives. So here are some facts that everyone agrees on. Women who have mammograms are 20 to 40% less likely to die of cancer if they're invited to have or actually have screening mammography than women who do not. And I'll talk about that distinction of being invited and actually having later. Here's another fact. Everyone agrees that annual screening starting at age 40 saves the most lives. And this is recognized by organizations who recommend starting later, some starting at age 50, for example, or screening less often than every year. The current guidelines of what age to start and how often to screen vary widely, and these conflicting guidelines did not arise because of different facts. They're because of different value judgments applied to the same facts. And you need to know what those value judgments are of each organization to see if they align with your values and priorities. But at the end of the day, the fact is annual screening starting at 40 saves the most lives. So let's look at some evidence that screening saves lives. Here's a list of all the randomized clinical trials done worldwide. And note that even the most recent of these is over 30 years old. And here are the results of those trials. The column on the right tells whether the risk of dying of breast cancer was reduced by an invitation to have a screening mammogram. That's a big concept, but let's skip over that for now. If the number in the column on the right is less than 1, then the women who were invited to have a mammogram were less likely to die. And that was true for most of the studies. But look at the two from Canada, the ones I've circled in red. They are the only ones that have a number higher than 1. They're the only studies where a woman was more likely to die of breast cancer if they were invited to have a mammogram. Really? What's a randomized trial? Well, it's a scientific experiment. Subjects are divided into 2 groups, and the group should ideally be identical in every aspect except the intervention being tested, in this case having a mammogram, and they should be randomly assigned to either group. You can see that there's an equal number of women in red. Those are the ones destined, they don't have it yet, but destined to get breast cancer. So this is theoretical at this point. And this is how the studies worked in most of the randomized trials. For example, in the study in New York, the very first one, they had a large number of women enrolled in a health insurance plan. They sent half of them invitations to come and have a mammogram, and they were the study group. The rest, who didn't get invitations, were the control group. They didn't even know there was a study going on, and they certainly didn't know that they were the control group. They just lived their lives. In Sweden, where health is delivered by counties, women in some counties received invitations and women in the other counties didn't. And that's how they made up their study and control groups. When randomization is done successfully, you can count the number of deaths in each arm after a prescribed period of time. And here you can see there was only 1 death in the group that was invited to screening, but in the group not invited, there were 3 deaths. So you would say that screening saved lives, or at least the invitation to screening saved lives, and it was due to the intervention. In almost all the trials where there were fewer deaths in the screened women, one could say that it was the invitation to screening that led to fewer deaths. So why were the Canadian trials the only ones that showed increased deaths in the women invited to screening? Okay, so this takes a bit of time to explain. There are 2 reasons. Most importantly, the randomization was corrupt. It was not random. Unlike the other trials, women were asked, in fact, they advertised in buses and so on, come and volunteer and be in our study. And women did. When they came to the screening center, the first thing that happened was they had a breast examination by a nurse, and then they were assigned to either the study or the control group. So let's say you're a nurse working in the clinic and Mrs. Jones comes in to volunteer. You do a breast exam and you find a lump in her breast when you examine her. Are you going to put her in the control group, knowing that she has a lump, which might even be cancer? Well, they weren't supposed to do this, but there were significantly more women with cancers put in the mammogram group than in the control group. And that's called randomization bias. So logically, if there are more women with lumps put in the mammogram group, there are more women with cancer in the mammogram group, and there were more women likely to die in the mammogram group. After all, these cancers were already large enough to feel, and they weren't early. Some of them had even spread to the lymph nodes. So that's one reason the Canadian trials were outliers. Another explanation is, let's say that you volunteer for the trial hoping to get put into the mammogram group, but you end up in the control group. You're disappointed, you really wanted a mammogram. So you go to your family doctor and ask to be sent for one, and they do send you for a mammogram. Now let's say that a small cancer is seen on that mammogram and you get treated and you do well and you don't die. 26% of the women assigned to the control group in the Canadian trial had mammograms outside the trial. And for those who had cancer and didn't die, their survival was still counted in the control group, even though they had the test that they weren't supposed to have. and that's called contamination, and it decreases the difference in outcomes between the control and the study arms, and it makes it look like mammograms don't save lives. And finally, the quality of the mammograms used in the Canadian study was substandard, and I don't mean substandard compared to the mammograms we do today. I want to show you this example of, and it's not a breast, of a scatter reduction grids. Now, that's something that's routinely used because it improves resolution on x-rays, including mammograms, and they were in common use for mammography when the study was underway. But the study leaders, who were not radiologists, chose not to use them. This is an example of using a scatter reduction grid. The image on the left was done without a grid, and you can hardly tell what body part it is. The image on the right is the same, but it's using a grid. And now we can see it's a side view of the lumbar spine, and you can see excellent detail. So here are two mammograms, and they're not taken decades apart. The one on the left is from the Canadian study, and you can see how blurry it is. The one on the right was taken from the Swedish 2-county trial, and it was taken around the same time. Even a layperson can see the difference in detail, and when mammograms are blurry like the Canadian one, they can hide cancers. So that's another reason the mammograms in the Canadian trial didn't save lives, and the Swedes showed significant mortality reduction. In fact, the Swedish trial of women 40 to 74 showed 31% mortality reduction, and they started screening in 1976 and 1978. So some who do not advocate optimal screening argue that in the era of modern therapy, our chemo's so good, it's not as important to find cancers early, but that's not true. This is a study from the Netherlands of almost 174,000 women, and it showed that even with modern therapy, survival still depends on early diagnosis, which of course relies on optimal screening. The Swedes published a major paper last year looking back at 58 years of data. They showed that women who chose to be screened were 60% less likely to die in the 10 years after diagnosis, and 47% less likely to die within 20 years of diagnosis than women who didn't have mammograms. Now, at any given time, women diagnosed received state-of-the-art treatment, whether they had screening or not. But the results of this long-term Swedish trial show that women who have participated in mammography screening obtain a significantly better benefit from the therapy available at the time than those who have not participated in screening. Now, even though those faulty Canadian trials were done between 35 and 40 years ago, and even though it's fairly widely acknowledged that they were poorly designed and poorly executed, the damage done to screening policy is ongoing. This article was about the 2014 release of the 25-year follow-up of the Canadian trials, and it was covered not just in the Canadian press, but worldwide. So I and others internationally are painfully familiar with the details of that trial, and we have to stay on guard to respond. In fact, in 2002, the World Health Organization recommended that this Canadian trial not be used in making guidelines, yet both the American and Canadian task forces that issue screening guidelines still include it. And the Canadian task force used it in their analysis that was published in December 2018. So this chart compares the Canadian trials with screening as it is currently performed. They enrolled 90,000 women. We have data on 4.5 million women using current screening. They showed no mortality reduction, but I've just shown you we have between 23 and 60% mortality reduction as it's currently performed. And their authors thought that there was 50% overdiagnosis. I'll explain that later. And currently it's believed that overdiagnosis is low and less than 10%. So we know from the old trials using old technology that screening saves lives. But what's the magnitude of the mortality reduction? How much? And the old trials give us an underestimate of that promise of mortality reduction. What about modern mammography? This observational study from Canada compared women who had mammography to those that didn't. And they obtained data on almost 3 million women who attended screening programs across Canada. They showed that women who have screening are overall 40% less likely to die of breast cancer than those who don't. And it was even better for younger women. For women 40 to 49, they were 44% less likely to die. Now, this study was a bit different. They looked at over 7,000 women diagnosed with breast cancer over a 10-year period at 2 of the hospitals in the Harvard system, and they looked at the women who died. 609 died of breast cancer, and 905 died of other causes. Most of the deaths, 71% of the deaths, occurred in the 20% of women who didn't have regular mammograms, and 29% of the deaths occurred in regularly screened women. Importantly, of all the breast cancer deaths, only 13% occurred in women 70 years or older, but 50% occurred in women under age 50, another important reason to screen between 40 and 49. 31% occurred in women initially diagnosed in their 40s. So this drives home the point that women should start screening at age 40. Breast cancer, of course, is less common in the 40s, but it grows faster, and we want to detect it as early as possible. The task forces only use the data from the randomized controlled trials to determine the benefits of screening. But randomized trials can only show mortality reduction. And I've told you there are other benefits of early detection that weren't even considered by the task forces. The ability to avoid a mastectomy, the ability to have a sentinel node biopsy instead of an axillary dissection, and even the option to avoid chemotherapy. Finding cancer early can mean the difference between a mastectomy and a lumpectomy. These researchers from New York showed that the other benefits of early detection we've just discussed. Women who have screening mammography less often are more likely to need chemo, have mastectomies, and require axillary dissection. Now, this is what lymphedema looks like. It's swelling in the arm and hand, and it occurs when there's blockage of the lymphatic vessels in the armpit, which is a side effect of that traditional armpit surgery done as part of breast cancer lymph node staging. I suspect many of you are nodding your heads either because you have it or know someone who has. It's usually permanent, and as you can imagine, it's life-changing. When women have a cancer detected early, they can have a sentinel node biopsy instead of an axillary dissection, and it has a much lower risk of lymphedema. Another reason we need to find cancers early, so women can avoid this complication, not just because they're less likely to die. Now, chemotherapy is awful, but unlike lymphedema, it's temporary. Now, with genomic testing of the actual tumor, many women can avoid chemo if their cancer is small and there are no positive nodes. Another reason to screen and find cancers early. So as I've told you, randomized trials can only measure whether there are fewer deaths. They don't measure whether there's reduced morbidity or suffering from harsh therapy. And since the task force only considered randomized trial, they didn't consider these other significant benefits. Randomized trials have shown a 15 to 20% mortality reduction in women invited to be screened. You've heard me say that a few times. Observational studies show 40 to 49% fewer deaths from breast cancer. Why that huge difference? Because in randomized trials, women assigned to have a mammogram don't always show up, even though they were invited to have it. So if a woman is in a trial and is invited to have a mammogram but doesn't, and later dies of breast cancer, her death is still counted in the mammogram group. Observational studies track results by who actually had the test, not whether they were invited or not. And this shows why observational studies always show better results. So the various organizations that do not support annual screening starting at 40 say that there are harms of screening, and they say that these harms outweigh the benefits. They must be pretty significant to outweigh saving lives and to outweigh avoiding harsh therapy. So let's look at them and see if you agree that the harms outweigh the benefits. Well, there's discomfort during a mammogram. Absolutely. Mammograms are uncomfortable, and they should be, but they shouldn't be excruciating. The reason we compress is to use less radiation and spread out the tissue so we can see better, and that includes seeing cancers. And the discomfort from a mammogram should be no more than a few seconds. All modern mammography machines have a release switch now, so the compression releases as soon as the exposure is made. It used to be that the technologist had to walk back to you and release the compression, but that's no longer the case. If a patient tells me that her last mammogram was unbearable, I tell her and the technologist that I want them to stop compressing when the woman tells her to. I'd rather have a less than perfect mammogram than have the woman refuse to have a mammogram. And these usually turn out just fine. So let's spend a couple of minutes talking about radiation. I know it's a concern for some of you, but notice that it's not even on the list of concerns for the task forces, and you'll see why. So the radiation risk of causing a breast cancer from mammography is primarily in younger women, less than 20 years old. The dose is a little higher than a chest x-ray. And did you know that there's radiation even when you go fly in an airplane? Well, not many of us worry about radiation when booking a vacation, but it's there. And there's natural source radiation, which is higher when you're at higher elevation because there's less shielding of cosmic radiation by the atmosphere. We don't think about getting radiation when we go to the top of Whistler or visit Denver, but we are. The dose of radiation from a mammogram is similar to the dose you get living for 7 weeks at sea level. And it's the same radiation as if you live for 3 or 4 weeks in Colorado. So to look a little deeper at the theoretical risk of radiation in mammograms, my colleagues at Sunnybrook in Toronto calculated that for 1,000 women aged 50 to 69 having a mammogram every 2 years, the radiation would hypothetically cause 0.27 cancers and 0.04 deaths. On the other hand, the mammograms would prevent 5 deaths, which is 125 times more than the lives lost, and save 105 years of life. So avoiding mammograms for fear of radiation is not a winning bet. And we know that annual mammograms save even more lives. So even though there's more radiation if you have annual mammograms than every other year, the math is still in favor. This graph is from an excellent website, densebreast-info.org, and it shows the radiation from various tests. You can see the very lowest radiation is from bone densitometry and chest x-rays, and mammography is the third lowest, just a little higher. This vertical blue line on the right is the amount that I'm allowed to get as somebody working in radiology to get every year, and that's felt to be safe. It's over 12 times the dose in a mammogram, and it's safe for me to have year after year. So certainly having a mammogram is a very trivial dose. False alarms are the biggest harm in the eyes of the task force, and here are the numbers. For every 1,000 women screened, 93% or 930 women will get a normal result. 7%, 70, will need additional tests, and the majority of them will only need 1 or more additional mammographic views or maybe an ultrasound. 16% or 11 of the 70 women who were recalled will need a needle biopsy. These are done with local freezing and should not be significantly more painful than a blood test. And of those 11 women who had the needle biopsy, 4 of them will be diagnosed with breast cancer. Now, the task forces think we should spare women the anxiety of false alarms, and that's why they recommend starting screening later and screening less often, even though they know that more women will die. So the question is, do you think that false alarms are a reason to not recommend screening? Well, researchers in Pittsburgh studied this. They surveyed all women attending for routine screening over a 5-month period. 97% of the women say they would have regular screening, even if it meant having a false alarm. 86% of them said they'd be willing to be recalled more often for more tests. And 82% said they'd be willing to have a needle biopsy if it might increase the chance of detecting cancer earlier. So that's what you have to consider when you decide whether to have a mammogram. Remember, 4 of those 11 needle biopsies showed cancer. So we've hinted at overdiagnosis. What is it? It's the theoretical possibility that some cancers we find at screening would probably never surface on their own, so there's no need to really know about them. And it's probable that some cancers grow so slowly they never become life-threatening. Unfortunately, when we have a diagnosis of cancer, we don't know which those are yet. Or a woman might die of something else before her cancer becomes life-threatening, like heart disease. She might have a heart attack and die. She might have a different cancer or be in a car accident. The likelihood of overdiagnosis in younger women is almost zero because they're less likely to have other diseases. The challenge is that most of us don't have a crystal ball. If you knew that you were going to be killed in a car accident tomorrow or die of a stroke 6 months from now, I would tell you you didn't need a mammogram. But assessing the importance of overdiagnosis is a subjective judgment that contrasts the value of unnecessary treatment of an overdiagnosed cancer with the value of saving a life from breast cancer. So you're comparing overdiagnosis from screening with increased mortality by not screening, which we could call overdying. And many women are willing to accept screening risks in order to reduce the likelihood of a breast cancer death. So the panel, which contains 14 members that carries a lot of weight in Canada for screening guidelines, is the Canadian Task Force on Preventive Healthcare. There are no breast cancer experts on this task force. There are family doctors, a pediatrician, a nephrologist, that's a kidney specialist, a psychologist, an occupational therapist, a chiropractor, a nurse, and a statistician. No breast cancer experts, but they issue guidelines about breast cancer screening, and they think the harm of transient anxiety outweighs the benefits of early detection. So this task force recommends no routine screening until age 50, and then after 50, only every 2 to 3 years. And they say that doctors should stop doing breast exams, and they say that women shouldn't do breast self-exams. Well, if you're not doing mammograms and you're not doing breast self-exams to find lumps, when will we find those cancers? Well, maybe when they're big enough you can see them bulging through your t-shirt. This comic in a newspaper in Vernon sums up their recommendation. Women shouldn't worry their pretty little heads about it. The task force exaggerated the harms of mammographic screening and they underestimated the benefits, and then they concluded that the harms outweigh the benefits, and they think we should have overdying instead of some transient anxiety. When the American task force made similar recommendations, doctors Hendrick and Helvey looked at the consequences for women turning 40 in the next 10 years and calculated that if they waited to have screening until age 50, 100,000 more of them would die. And if they waited till 50 and had screening every 2 years, compared to having annual mammograms starting at 40. And it makes sense to screen women in their 40s, but women in age 40 to 49 are not offered breast screening in all provinces. Women in their 40s are often caring for young children and aging parents. They're often working and contributing to the economy, and I would argue that they are not expendable. All women in Canada should have access to screening starting at 40 and ideally annually. Currently, 7 provinces allow women to self-refer every 2 years starting at age 50. 3 provinces start at 40. In British Columbia, a woman with a mother or sister with breast cancer can come annually. And in some provinces, women are allowed to come annually if they have dense breasts. Now, even the Canadian Task Force agrees that it would save more lives, but they think it's more important to spare women the anxiety of a recall. So I hope you're convinced that screening mammography should start at age 40, but when should it stop? The old randomized trials included women only up to age 74. So our task force recommends stopping screening then. And some provinces have defaulted to that. But I've shown you that breast cancer risk increases with age. If a woman's in good health with a life expectancy of 10 years, and she's well enough to have treatment, if we find a cancer, then it's worth continuing to screen to find those cancers when they are small. Because if we don't, and they're allowed to grow large enough to be felt as a lump, more extensive surgery will be required. And for some women, by the time the lump is found, she may be elderly, her health may not be as good, and she may be able to have, she may be less able, to be treated. The statistics are that a woman in North America who has lived to age 75 has an average life expectancy of 12 to 14 additional years. Overdiagnosis is likely low, between 1 and 10%, and screening benefits significantly outweigh the risk of overdiagnosis until age 90. So they still should be screened, and that includes women who have had breast cancer, which I'll talk about later. Now, these 2 studies show that up to 10% of screening mammograms in their practices were in women 75 or older. A high number of the cancers were found in these women, and most were invasive. And in the study that did follow up to find out how many of the women went on to have surgery, 98% of them did. So now, many organizations recommend that an individual woman's decision to continue screening should be based on her health, her life expectancy, and her values. So what's the issue with breast density? Okay, picture time. We are pretty good at recognizing cancer on a mammogram when we can see it. Here's an obvious cancer in a 55-year-old woman. And the reason I say it's obvious, because it's got jaggedy edges, and you may be able to see there's some fine white dots. Those are suspicious calcifications that we can see on the mammogram. And it's relatively easy to see breast cancer when the breast is mainly fatty, like this one and like this one. Fat is dark gray on a mammogram, so cancer, which is white, shows up relatively easily. But normal breasts vary considerably, and as the amount of dense tissue, the white stuff, increases relative to fat, it becomes harder to see cancers which are white. It's like trying to see a snowball in a snowstorm. And some women have almost no fat, and they're virtually completely dense. Radiologists grade density into 4 categories. Some provinces use a quartile system where the radiologist subjectively looks and decides what percentage of the area is dense. For example, less than 25%, 25 to 50, 50 to 75, and greater than 75%. The new system that's been around now since 2014 uses the ABCD system, and it's based on the possibility of masking a cancer. So a breast with even less dense tissue, if it's concentrated in a small area, could still be graded as a category D. Now, not all provinces are using the 4-category system. They only ask radiologists to decide if the density is greater than or less than 75%. Here's an example of dense tissue hiding a cancer. This is an acquaintance of mine, and she had a negative mammogram at age 50. But negative in a woman with dense breasts doesn't always mean no cancer. You can't see anything sticking out as looking abnormal. But 8 months later, she came back because she found a lump in her left breast. And you can see we've repeated the mammogram. This triangle is a marker that the technologist taped on her skin over the lump. We repeated the mammogram, and we even did 3D mammography for her, and we couldn't see anything abnormal. It was still negative. But because she had a lump and we did her ultrasound, we saw she had a cancer, and it was not small. It was 3.2 centimeters, and it had already spread to her lymph nodes. When a cancer is diagnosed after the most recent screening mammogram is negative, it's called an interval cancers. And interval cancer is 18 times more common in women with dense breasts. And we see cases like this every single week. Here's the thing, dense breasts are normal and they're common. Every woman has fat, glands, and fibrous tissue in her breasts, but the proportions vary, as I've shown you, from one woman to another. Breasts that have more than 50% glands and fibrous tissue are called dense breasts. And more than 40% of women over the age of 40 have dense breasts, and the only way to tell is on a mammogram. Some breasts become less dense and more fatty with age, but not always. So while it's normal to have dense breasts, women need to know if they have dense breasts so they can understand the implications. In Canada, there are 3.4 million women over the age of 40 with dense breasts, and over 800,000 women in Canada are in that highest density category, category D. But only about 60% of eligible women even have mammograms, so the rest have no way of knowing their density. Now, here's why it's important to know if you have dense breasts. Women in category D, the densest breasts, are 4 to 6 times higher risk of developing breast cancer than women with fatty breasts. So they're at a higher risk of breast cancer, and then there's the masking effect that makes it harder for us to see cancer in a woman with dense breasts on her mammogram because both are white. Normal tissue's white, cancers are white. And when women with dense breasts get cancer, they're typically larger and more often node positive, and they have that higher risk of getting an interval cancer, and interval cancers have a worse prognosis than screen-detected cancers. Breast density can be determined only on a mammogram, not by breast size or by touch. Your doctor can't tell when doing a physical exam. Lumpy breasts are not the same as dense breasts. You can have lumpy breasts and they can be completely fatty. Both fatty and dense breasts can feel soft, firm, or lumpy. In most provinces, the density is determined by the radiologist when they look at the mammogram. Some provinces are starting to use software to measure the level of density. Nova Scotia, Prince Edward Island, and Alberta are starting to use software. So let's talk about the role of ultrasound in women with dense breasts. For many years, it was believed that ultrasound could not find cancers that were not visible on the mammogram and were still too small to feel. But we published this paper 25 years ago, and it was followed by work from multiple other institutions and then multi-center trials that showed that high resolution can find cancers that are too small to be feelable, and they're missed on mammograms largely because of dense breast tissue. This multi-center trial found 5.3 cancers per 1,000 women screened in the first year, and an average of 4.3 cancers per 1,000 women over the following 3 years. 94% of the cancers that they found were invasive, and they were small. Their median size was 10 millimeters. And 96% were node negative. That's when you want to find cancers, when they're small and they haven't yet spread to the nodes. These are the cancers that can be treated less aggressively, and they're not the cancers that are over-detected. More on this later. Ultrasound can be done with a handheld probe or with an automated probe. This is a large probe that automatically scans about 1/3 of the breast, and some people call it ABUS, or automated breast ultrasound. It goes by a number of names. I'm going to call it ABUS because it's faster, but different companies have different names for it. There are ABUS machines available in 3 clinics in Ontario and many in Alberta. Any ordinary ultrasound machine can do breast ultrasound, but many clinics don't offer it. And you might have trouble getting your family doctor to refer you for screening ultrasound. In spite of all the emerging evidence on breast density in the 1970s, 80s, and early 2000s, in fact, it was still not being shared with women, and in many cases with their doctors. Nancy Capello was a PhD in educational leadership in Connecticut. In 2004, only weeks after her routine annual screening mammogram was negative, she found a lump in her breast, and after ultrasound showed a cancer, she was diagnosed as stage 3C with 13 positive axillary nodes. She started a grassroots movement to get women notified when they have dense breasts, and since the medical establishment was pushing her away, she went to legislators. There are now 13 states and the District of Columbia with some degree of breast density notification, and the FDA is working on all women in the US being notified of their breast density. Connecticut was the first state to pass legislation, because that's where Nancy Capello lived, and they now have several years of data. They're finding an additional 3.4 cancers per 1,000 women, and cancers that were missed on their mammograms. They're almost all small, invasive, and node negative, like in that study I showed you. Here are some cases given to me by my colleague at Yale of small cancers found on ultrasound that were missed on mammograms. So we know from decades of research that mammograms save lives, and you'll often hear that mammography is the only test that's been shown to reduce deaths from breast cancer. And strictly speaking, that's true, but why is that? The only way to make that claim is by doing a randomized trial like the many I've shown you, and there have been many on screening mammography. Now, this excuse is still being used across Canada to not deny women access to supplemental screening screening ultrasounds. There is a randomized trial of ultrasound being done now in Japan, and the early results suggest that it too will show reduced mortality. Other methods for screening used in select populations, like ultrasound, MRI, and molecular breast imaging, have not been studied for mortality reduction, which raises the question, why do some tests get approval without a randomized trial, but not others? And do we really need a new trial for each test? I and many others say no. We already know from the screening trials of mammography that the reason lives are saved is by finding small cancers before they've spread to the lymph nodes. So any other test that finds those same kinds of cancers will also save lives. And I've shown you that this is the exact kind of cancer that ultrasound finds. So we're 10 years behind the US in breast density notification and access to screening ultrasound, but the good news is a group of women who've had breast cancer have formed an education and advocacy nonprofit called Dense Breast Canada. Their Facebook page launched in January 2017. They have Twitter accounts in English and French, and their website launched in English and French as well, all with the help of volunteers. There are no paid staff. In 2018, thanks to their work, British Columbia became the first province to notify women of their breast density when they have a screening mammogram. And recently, Nova Scotia and Prince Edward Island have followed suit. Alberta and New Brunswick have committed to notifying all women, but we have so much more work to do. Saskatchewan, Manitoba, and Ontario are only notifying women in the highest category, and they're not even notifying women directly, they're just recalling them more annually. The problem is that women in category C are misled to believe that they are not dense. So if for updates in your province, there are instructions on the Dense Breast Canada website. If you live in Ontario, New Brunswick, Quebec, or Alberta, you can ask your doctor because they have that information on the report they get from screening. And we're hoping that these provinces will start telling women directly, because even though your doctors have been receiving the information for years, many of them don't volunteer that information to the patient, and it's up to the woman to ask their doctor if they're dense. Now, your doctor may be unaware of the risks of dense breasts, and he or she may be reluctant to order an ultrasound because they don't want to put you through the anxiety of a false alarm. So if you can handle some transient anxiety, better safe than sorry, and think how anxious you'd be if you had a late diagnosis of breast cancer. Family doctors are blitzed by the Canadian Task Force and misinformed about needle biopsies. As I told you, these are done when there's even a small possibility of cancer, and they're done with freezing, and most women tell me that they're way less uncomfortable than having a blood test from the arm or even a trip to the dentist. In fact, the funniest thing a patient said to me after her needle biopsy was, "Dr. Gordon, I have shoes that are more uncomfortable than that needle." So what about some other tests? You may have heard of 3D mammography, which is also called tomosynthesis. It's a better mammogram than the standard 2D mammograms, but it's not yet being used in any of the screening programs in Canada. It is available in some clinics across Canada for diagnostics, and in British Columbia, at the clinic where I work, we use it for women who've had cancer who are coming for their annual follow-ups. Here's some examples of ultrasound detected cancers, though, from my colleague at Yale, that were missed on tomosynthesis. So even tomosynthesis doesn't work as well as ultrasound at finding cancers in dense breasts. MRI is the most sensitive test at finding breast cancer, but it's very expensive. It requires an intravenous injection. It has the most false alarms, and a lot of women can't tolerate it because of claustrophobia, and you have to be in the machine for a long time. Not all women can have MRI, and there is concern about the gadolinium, the dye that they use, being deposited in the body, and we don't know the long-term effects of that injected material. There is a way of doing breast MRI that's much faster for the women in the machine and faster for the radiologist to read. So the test is being studied now, and if they can bring down the cost, it might be used more often at women at higher than average risk, but we're not there yet. Another test you may have heard of is contrast enhanced dual energy mammography, and this is a test that shows tremendous promise. It finds almost as many cancers as MRI, but with fewer false alarms, and you don't have to go into the MRI magnet. It also requires an intravenous injection, but it uses a different dye than the one that's used with MRI, and it's much less costly. I'm aware that my colleagues in London, Ontario have started using this test. And there are 2 nuclear medicine tests that can find cancer, but both of them require an intravenous injection of radioactivity. So unlike mammography, the radiation dose isn't to just the breast, the low dose that I told you about. It goes to the whole body because it goes through the bloodstream, and especially the pelvis, because it's collected in the bladder and excreted in the urine. And what's in the pelvis that we don't want exposed to radiation if possible? The ovaries in younger women. So the effective dose from an injection is 6 times higher than the radiation for a mammogram. And another thing about the nuclear medicine tests are not as good at finding lobular cancers. So whether or not you've had breast cancer, what should you do if you have dense breasts? Well, you should continue having mammograms because they detect cancer that's not visible on ultrasound. You can't just have ultrasound screening. I recommend that you perform regular breast self-exams between screenings and look for any change that might be cancer that might not be seen on your mammogram. And if you notice a change, do go and see your doctor. Also, consider modifying your lifestyle factors to decrease your risk of getting cancer or getting a recurrence, such as getting to and staying at a healthy weight, doing moderate amounts of exercise, decreasing your alcohol intake, and decreasing your hormone therapy use. Speak to your doctor about the level of your breast density. What category are you? What are the associated risks? Are there additional risk factors you have? And then choose the best screening options for you. To improve early cancer detection in dense breasts, consider additional screening like ultrasound or MRI, especially if you've had cancer. And if you choose to have these additional tests like ultrasound, I recommend you not have them at the same time as your mammogram each year, but that you alternate them. So you have a mammogram and 6 months later you have an ultrasound, and 6 months later you have the mammogram, and so on. If you are diagnosed with breast cancer, consider having an MRI before you choose your surgery so that you know if there's any additional tumors hiding before you decide on a lumpectomy versus mastectomy, and to check the other breast for any hidden cancers. If you have had cancer, you're at a higher risk of getting a second cancer than women who haven't had cancer. And if you've had cancer and you have dense breast, push to have ultrasound or MRI in addition to your follow-up mammograms. In fact, the American College of Radiology now recommends that for women who've had cancer, who have dense breasts, and have annual MRIs. This study showed that if you've had cancer in one breast and you have dense tissue, you're at a higher risk of getting breast cancer in the other breast. And if your doctor won't give you a requisition for an ultrasound or MRI, or if they do, but you get turned down by the radiology department, that's when you have to become an advocate. Get in touch with Dense Breast Canada. Speak to your representative in your provincial legislature. Work with others you know who have dense breasts and may not be getting optimal follow-up screening. These research showed that getting breast cancer in the other breast is higher in women with dense breasts. They also showed that dense breast tissue can decrease in women on tamoxifen or on chemo, but not from radiation. And if a woman's breast density decreases more than 10%, it may be an indication that they're actually of a lower risk of getting breast cancer on the other side. Women who've had breast cancer are at higher risk of it coming back in the same breast if they have dense tissue, and the risk is higher in women who haven't had radiation. After lumpectomy and radiation, the overall risk of local recurrence is about 10 to 15% in 10 years. But women with high mammographic density have a much greater risk of local recurrence compared to women with the least dense breasts, 21% compared with 5%. The risk of local recurrence at 10 years was higher for women who didn't receive radiotherapy at 22%, rather than for women who did at 10%. Sorry. Here are the latest recommendations for breast MRI from the American College of Radiology. For women with a genetic-based increased risk, like women with the breast cancer gene, and their untested first-degree relatives, those with a calculated lifetime risk of greater than 20%, or those who've had mantle radiation therapy for Hodgkin's disease at a young age, they recommend supplemental screening with contrast-enhanced breast MRI. They also recommend breast MRI for women with a personal history of breast cancer who have dense tissue, or women who've had breast cancer diagnosed before age 50, whether or not they have dense tissue. Others with histories of breast cancer and those with atypia on a biopsy should consider additional surveillance with MRI, especially if they have other risk factors like family history and so on. So that's a lot of information for one lecture, but here's what I want you to remember. All women should have mammograms, ideally annually starting at age 40, but certainly go as often as your screening program will allow. For example, in British Columbia, they only send a reminder letter after 2 years, but if a woman remembers to phone 18 months after her last mammogram, they'll let her come then. Remember that some cancers are not detectable on a mammogram, so it's worth doing breast self-exams. Get to know what your normal feels like, so you'll know whether there's been a change. Remember that most abnormalities on mammograms are not cancer, So try not to panic if you get recalled from a screening mammogram. Remember, women who have mammograms are 40% less likely to die of breast cancer than women who don't. 3D mammography finds more cancers than 2D and has fewer false alarms, but it's still not as good as ultrasound at finding cancers that are missed in dense breasts. And when you look at the real numbers for mortality reduction and the other benefits of early detection, the benefits of screening outweigh the harms. Ultrasound finds cancer missed on mammograms in dense breasts, even if 3D mammography is used. And remember the two risks of having dense breasts. The risk of reduction of accuracy of the mammography because the cancers are masked in normal dense tissue, and the dense breasts are an independent risk factor for getting breast cancer. It's important to know your breast density and understand the implications. Please speak to your family doctor about your risk factors and tell your friends, families, colleagues what you've learned about screening and density. Check out the Dense Breast Canada website, Facebook page, and Twitter, and tell your friends, family, and colleagues. Follow me on Twitter too, for that matter. Women need to be informed and empowered to look after their breast health. Please find out your own density. Offer to help raise awareness by sharing your story on the Dense Breast Canada website and help advocate for optimal screening for all women in Canada. And again, here are the ways you can get in touch with the Canadian Cancer Survivor Network. Thanks so much for your invitation, and I'm happy to take some questions.
Thank you, Dr. Gordon. We now can jump to our question and answer session. A reminder to everyone who's joined us today, you still have the opportunity to ask a question at any time in the next couple of minutes in the top of your window on your right-hand side. So we do have a few questions that have been submitted. Dr. Gordon, can you recommend any courses that GPs can take on breast density and how to appropriately discuss and advise their patients about mammograms, and particularly for those under the age of 50?
That's a really good question, because as I told you, the Canadian family doctors are kind of blitzed by the task force and getting all that misinformation. There is actually a course, and it's offered by that website I told you. It's densebreast-info.org. They're a website that has sections for patients and for doctors. Now, doctors, family doctors and specialists are always looking for ways to get continuing medical education credits. And the densebreastinfo.org website offers courses that do provide credits. Now, I think it's a nominal cost for their course. It might be $35, but last year there was a month, and it might have been Breast Cancer Awareness Month, I can't remember exactly, when they offered the course for free. So that's certainly worth sharing with your family doctor. And it's that whole website is evidence-based. They give references, like I gave in this talk, from the peer-reviewed literature for everything that they teach.
Our second question is, what is the best option for children of women who have gone through breast cancer?
So it would be reasonable to start screening women earlier if they've had a mother with breast cancer, but the rules that we use are, if mom had breast cancer at age 60, we don't start earlier than 40. We start 10 years younger than the age of diagnosis than the mother, but not younger than age 30. So if mom had breast cancer at 43, we would start the daughter at age 33. But even with a family history in an older mom, we would still start screening at 40.
The next question is, why don't we count women who live with metastatic disease who have had dense breasts when they were first diagnosed? I did, but it was not rigorous, a randomized count. I just asked women who are metastatic if they knew that their density were when they were diagnosed. And according to this, 75% of women who knew their breast density said their breasts were dense. If this is true, this means women with breast dense are grossly overrepresented in a metastatic setting. We could get this data from real-world evidence. Would it help to move breast density notification in ultrasounds for dense breasts if we did this? Or should we just wait for the results from the Japanese trial?
So as I said, we already know from the observational studies of breast ultrasound that we're finding 3 to 4 cancers per 1,000 women screened. We know from the preliminary data from the Japanese study that there are fewer interval cancers among the women who were getting the ultrasounds. And in my view, and many of my expert colleagues, that's sufficient evidence to proceed with doing supplemental screening on women with dense breasts. The person who asked the question is absolutely right. Women with dense breasts who are only being screened with mammography are being discriminated against. And there was a study done in Italy that I didn't show you, where the women who were non-dense were just having mammograms, and the women who were dense were having mammograms and ultrasounds. And what they saw was that the interval cancer rate was the same between those two groups. Now, normally, women with dense breasts have a much higher rate of interval cancers, the ones that are missed on the mammogram and found as a lump between screens. But by offering women in Italy ultrasound, if they were dense, they leveled the playing field. They removed that discrimination factor. So this is why it really helps when women advocate for better screening. As you heard, I mean, I published that paper 25 years ago. The medical system and governments who fund medicine do not listen to doctors. They listen to voters. And the only reason we got breast density notification in British Columbia and Nova Scotia and PEI, and hopefully other provinces to follow, is because of women advocating, not me. I'm teaching you, but I want you to start making noise. Go talk to your representatives in your provincial parliaments. They're the people who have the power to change. In fact, in British Columbia, our screening program did not want to tell women their density, but when the Women from Dense Breast Canada spoke up and convinced the provincial, and BC we call them MLAs, not MPPs, they went to the health minister and convinced him that it was the right thing to do, and he forced it on the screening program. So that's the advocacy that plays such a huge role in improving the situation for the women to come after you.
We do have one more question if we have time. If you are breastfeeding, when and what type of screening should I get?
So if you're in the screening age group and you're breastfeeding, we actually recommend that you continue with whatever screening you would normally have. Breastfeeding does make it harder to see cancers on a mammogram because it increases the density tremendously. But what we do is we get women to breastfeed just before they have the mammogram. So we try to get them to reduce their breast density. But if you're a woman who would otherwise be having mammograms, keep having them. Not when you're pregnant, but if you're at high risk, your mom's had breast cancer and you're breastfeeding, which is a good thing, of course, have your mammogram, have your ultrasound, whatever you would normally have.
So that brings our Q&A session to an end. I just want to take this moment to that also brings our webinar to an end for today. If anyone does have any further questions, please feel free to direct them to me at partnership. So that's partnership with an S at survivornet.ca. Again, that's partnerships at survivornet.ca. And I'll be more than happy to pass them along to Dr. Gordon. I also want to thank everyone for attending today's webinar. We also want to take this opportunity to thank Dr. Paula Gordon again for her presentation today. Just a reminder that today's webinar will be available in full on CCSN's YouTube and SlideShare accounts tomorrow. And additionally, registrants of today's webinar will receive an email containing the links to today's webinar. Our next webinar, Goals of Treatment, that will be presented by Dr. Krista Noonan, is scheduled for Thursday, February 27th, less than 2 weeks from now. And again, that's 1 p.m. Eastern Standard Time. To register for any of CCSN's upcoming webinars, please visit survivornet.ca. So thank you everyone for attending, and we all hope that everyone enjoys the rest of your day. Thanks so much.